Hello, once again. Good morning, good afternoon, good evening, whatever time it is you're listening in. I want to welcome you to this second session on our topic, immunizations. My name is Violet Aswa Akek. I'm a lecturer of pediatrics in the Department of Clinical Medicine at the Kenya Medical Training College. Again, I want to remind you that this session or this lesson is meant for clinical medicine students, but again, you can always listen to it as part of a revision or just to listen to a simplified way of looking at things. Remember to subscribe and also check the notification bell so that any other time we post something that may be of interest to you, you may be able to know in good time. So, welcome. In this session, we shall be looking at the policy guidelines on immunizations, that is in Kenya. Then we shall look at the National Immunization Schedule as released in 2023 by the National Immunizations and Vaccines Program. We shall look at some of the adverse effects that we should expect after vaccinating our children. And then we shall look at vaccine management and the cold chain. Now, in our previous session, we looked at the general defense mechanisms. You'll remember that. We looked at the types of vaccines. We looked at the effect of maternal antibodies and how this affects the timing of immunization. And also, we introduced the immunization agenda globally as well as in Kenya. Having looked at all that, now let us look at the policy guidelines on immunization in Kenya. So, the guidelines have these principles which usually govern the immunization service delivery in our country. Number one, and this is actually lifted from the National Immunizations Policy of 2023 Kenya. So, the Ministry of Health will ensure that there is uninterrupted supply for all available vaccines to all eligible Kenyans. And in this case, we are making reference to children and adolescents. So that is number one guiding principle. Availability of the vaccines in a manner that is not interrupted. That way, no children come for vaccines and they find that the vaccines are out of stock, because that will be a huge missed opportunity. Number two, guiding principle is that vaccines provided by the government shall be provided free of charge. That means no child is supposed to pay for the primary vaccines except for those vaccines that are listed as travelers vaccinations. For those ones they pay, like the yellow fever, they pay, okay? But otherwise, all the other primary vaccines are supposed to be administered free of charge. Guiding principle number three, all immunization services shall be at all immunizing health facilities provided on all working days and on demand. That means no child should be able to come to hospital and they be told, oh, today is a Thursday or a Friday, we don't immunize. No, this service should be available every day of the week and on demand. Guiding principle number four, all efforts shall be made to screen children for vaccination status on joining school. That means that when the children are being enrolled for the playgroup entrance, because these days they begin school at the playgroup level, they should be screened for adequacy of immunization. That means they should be able to be identified at that point, and those who have missed certain vaccines, then they should be vaccinated at that point. Guiding principle number five, all immunizing health facilities shall report through the MOH systems as prescribed on all vaccines administered, whether they are procured by the government of Kenya or by private entities. That means that so long as a health facility, whether it's public or private, so long as it is listed as an immunizing center, then they shall be able to make their reports according to how the Ministry of Health has prescribed it on specific reporting forms and formats to the government of Kenya, and returns made accordingly. Guiding principle number 6, all vaccines for human use in Kenya must meet quality requirements as shall be determined by the Pharmacy and Poisons Board, and they must also be duly approved for use by the same board. So we are saying that all vaccines, a vaccine that has not met the requirements, and has not been approved by the Pharmacy and Poisons Board should not be administered to any Kenyan child or adult. Guiding principle number 7, all vaccines for human use must be stored in specialized vaccine refrigerators as prescribed by the WHO standards. So, the cold chain here, we are talking about it, the refrigeration must meet the WHO standards. So, how does a facility know what are the standards? Then they make reference to the National Vaccines and Immunization Program or from the WHO official website. That is where you can find the standards. And make sure that the refrigerators at the facility level are meeting those minimum standards. Guiding principle number 8, all injectable vaccines must only be administered by duly qualified and registered clinicians or authorized health practitioners. That is to say that anybody who has not been through a health training regarding vaccine provision is not supposed to give or offer or provide this service. It becomes an offense. Guiding principle number 9, all injectable vaccines are to be administered using non-reusable injection devices. That means one use for one patient. We don't recycle syringes, we don't recycle needles. Only one use, and they should be disposed of in a safe manner in the safety boxes. Guiding principle number 10, reconstitution of all freeze-dried vaccines must only be done with their matching diluents as provided by the specific manufacturer. And usually, you must read the manufacturer's instructions when diluting the freeze-dried vaccines. So remember, every freeze-dried vaccines should only be diluted with the matching diluent from the manufacturer. Guiding principle number 11, all reconstituted multi-dose vial vaccines must be discarded after the manufacturer's prescribed maximum duration of use. That means every time you have reconstituted a vaccine, always remember to read the instructions from the manufacturer on the label. There will usually be a maximum time duration within which that vaccine must be used. And if it is not used within that time duration, it should be discarded. Those instructions must be followed very strictly because they speak to the potency of the vaccine. Guiding principle number 12, all unused doses of a liquid multi-dose vial vaccine without a preservative must be discarded at the end of the vaccination session or 6 hours after opening it, whichever comes first. That means if the vaccination session takes longer than 6 hours and the vaccine has not been fully utilized, it should be discarded. So whichever comes first. Is it the end of the session? If it comes before 6 hours, if the session has ended, it cannot be stored for use the next day. It should be discarded. If the session is still going on and the vial was opened and it's already 6 hours, it should be discarded also. That is very important. Guiding principle number 13, screening for immune status of individuals, and this includes infants, prior to vaccination is not recommended. However, where special circumstances will dictate, this should be overseen by a qualified, authorized practitioner. All children who come in for vaccines, so long as they are due for it, they should receive it. Guiding principle number 14, routine screening for HIV status prior to vaccination is not recommended, except in special circumstances as determined by a consultant practitioner, which means that you shall not withhold administration of a vaccine because of the HIV status, or rather, you shall not first of all want to find out the HIV status of a child before you want to give them the vaccine. However, as we shall see, children who are HIV infected and are symptomatic, those ones will not receive live attenuated vaccines. Guiding principle number 15, all health workers must advocate for comprehensive utilization of immunization services to their community leaders and members. That means as a health worker, you become the advocate. You must advocate and preach the gospel of the benefits of immunization and vaccine reception to the community. We need to help them understand the importance of getting vaccinated as a means of preventing the mortality and morbidity caused by vaccine preventable diseases. That becomes our job. And it is not difficult. We can do that in our churches. We can do that when patients are waiting in the bay to be seen. So long as triaging is going on, those who are not very sick, before services begin, they can be taught these things. Principle number 16. Some vaccine preventable diseases are notifiable. Therefore, information on all the suspected cases of these diseases must be fully documented and must also be reported forward immediately to the Division of Disease Surveillance and Response of the Ministry of Health in whatever county you may be practicing in. What are some of these notifiable diseases? We have TB, suspected polio, and you will only talk of suspected polio using the acute flaccid paralysis as an indicator. Diphtheria, pertussis, maternal tetanus, neonatal tetanus, measles, meningitis, yellow fever, and for yellow fever again, you will use hemorrhagic fever as an indicator. Then we have rubella, influenza, and rabies. These are vaccine preventable diseases that are notifiable. They must be reported to the Disease Surveillance and Response team of the Ministry of Health at whatever level. Once these diseases are reported, they must be duly investigated according to the prescribed guidelines. Okay. Principle number 17. During ante and postnatal visits, health workers should emphasize to mothers on the importance of breastfeeding as a source of early antibodies and a route of continuous transfer of cell-mediated immunity to their babies. This is also part of the education that all pregnant mothers and postnatal mothers should receive on a regular basis, so long as they have come into contact with a healthcare provider. We must emphasize on the importance of breastfeeding. Breast milk is the best meal for a young infant up to 6 months. That is the meal God intended for babies before 6 months of age. It is not only the best meal, but it also comes with benefits. And this benefit as regards immunization should be made known to mothers that their breast milk contains antibodies that are helpful in preventing certain infections in their growing babies. This is very important information. Principle number 18. All efforts must be made by health workers to prevent dropouts from all immunization schedules through careful counseling of clients. And this counseling should address the importance of vaccines, should also address the possible side effects and what to do about them. So a mother should not be surprised at an adverse effect caused by a vaccine. This is information that should be given to these mothers at the point and even before their children are receiving vaccines or they're being immunized. And also, this counseling or information must contain the consequences of not completing the schedule. Therefore, we need contact tracing, a means of finding out who has not come back for their routine immunization dates and how are we able to reach them. Before we even do that, we need to be able to have let the mothers and caregivers know why vaccines are important, what are some of the adverse effects that may be associated with them. That does not make a vaccine bad. It is just an adverse effect. In fact, it could just be a means of knowing that indeed the body is responding to the vaccine in the right way. And therefore, we need to tell the mothers what to do. For example, if it is a high fever, what to do. If it is pain at the site of injection. See, these are not harmful things, but they're just part of what happens after a vaccine has been administered. And then it is very important for the mothers and caregivers to understand what is likely to happen if they are not bringing their children to complete the vaccination schedules. This is very important information. And mothers, being who they are, every mother wants the best for their child. And once a mother understands the importance of a certain strategy or treatment or anything that is being done to their child or for their child, most of them will usually comply. So we take advantage of that particular trait. Guiding principle number 19. We are saying that all efforts must be made by healthcare workers to identify and respond to missed opportunities for vaccinations. That means as a healthcare provider, wherever you're working, plans must be made to help you or to make you be able to identify as well as respond to any missed opportunities. And how can we do that? Number one is by screening all children who are aged less than 5 years and are coming in for whatever reason to be seen at the health facility. These children should be screened to find out what is their vaccination or immunization status. And it is very easy because as healthcare providers and in pediatrics, we have taught you that as part of history taking in children, one of the things that you must always address is their immunization status. You must always look at the immunization status of the child against their age to see its adequacy. That means that any child who has missed a particular vaccine should not leave hospital without that particular immunization issue being resolved or sorted out. If they are being admitted, they can be vaccinated while they are still in hospital unless there is a contraindication. If they are being seen as outpatient patients, then they must pass through the immunization clinic for that vaccine to be administered. That is number one. The other means of making sure that we identify the children that have missed vaccines at whatever level is during the time when they are joining school. We would be talking about the playgroup children. They're usually very young, around 4 years old. So at this level also, we can be able to identify them and make sure that their immunization needs are being met. This is usually a collaboration between the Ministry of Health and the Ministry of Education. That means that the preschool teachers need to be empowered in order to be able to do the screening and be able to collaborate with the Ministry of Health so that these children can have their immunization status updated. Having said that, then we have the older children, the girls who are aged 10 years to 14. Again, these ones need to be screened most of the time, again, when they're coming to hospital or just at school. We may have campaigns that do that. So all girls from the age of 10 to 14 need to be screened for their vaccination status of the human papilloma virus. This is very important because of its role in the prevention of cancer of the cervix later in life. We also need to have means of screening all women that are aged between 15 to 49 years, that is the childbearing age, at our health facilities, particularly for their vaccination status regarding tetanus and diphtheria. Remember, as we mentioned about tetanus, we said that it's very important that a mother is able to pass passive immunity to her unborn baby so that we can prevent neonatal tetanus, which is still a very important infection in our setting. Having said that, then, let us look at the National Immunization Schedule of Kenya as at 2023. So we begin with what happens at birth. At birth, 2 vaccines are given. And while we are looking at the National Immunization Schedule, we shall be looking at the vaccine dose, the dosage, the age at which that vaccine is supposed to be given, and the route of administration for every vaccine from birth through to adolescence. So we are saying that at birth, there are 2 vaccines that can be given, or they should be given. That is the BCG and the bivalent oral polio vaccine. This is usually known as the birth dose. The first oral polio vaccine that is given at birth or before the first 2 weeks of life is known as the birth polio vaccine. So let us start with the BCG. BCG should be given at birth, and here we are making reference to children who are born at hospital, or they may have been born at home, but they have come to hospital immediately. Those ones are being given the birth dose. Then there are those children who may not have been born in hospital, but they were born elsewhere, and then you meet them for the first time much later after their birth. So we are saying either at birth or at first contact, whatever other time you meet them for the first time after they have been born, BCG must be administered. So if it is at birth or you're meeting them after birth but before they are 1 year old, the dose is usually 0.05 ml. If you're meeting them for the first time after the age of 1 year and they have never received the BCG vaccine, then the dose is doubled and it is 0.01 ml. So remember the 2 dosage differences between the infant who is less than 1 year old and the one who is beyond, the child who is beyond infancy. The dose for the infant and at birth is 0.05 ml, and the dose for the one who is more than 1 year old is 0.1 ml. The route is intradermal, and this route is very important for you to know and practice over and over, because if the BCG vaccine is not given intradermally and say it is given maybe subcutaneously, that sometimes is the reason why you have some of the complications that are associated with it. and sometimes also the vaccine will become ineffective. So make sure that when you're going out for your practicals, you really practice how to administer the BCG vaccine intradermally. Like I said, the other vaccine that is given at birth is the bivalent oral polio vaccine. Just like the name suggests, oral polio vaccine, it is administered orally, and the dosage is 2 drops. Now, there are those children, like we said, who may not be born at hospital, but they come in, they are born at home or elsewhere, and then they come in. For those ones who you meet before, that is within the first 2 weeks of life, they will still be eligible for the oral polio vaccine birth dose. If they're older than 2 weeks, then they're not eligible for the birth dosing. That is for oral polio vaccine. Then we come to the age of 6 weeks. So it is the age of 6 weeks for those whose birth dosages were given at birth. They come in at 6 weeks. If they were not born in hospital and then they did not come to hospital immediately, so we are talking about the age of 6 weeks or first contact after 6 weeks. These children should receive the oral polio vaccine 1. Remember, the one at birth was called birth dose or 0. And then we have the OPV 1, which is given at 6 months. The dose remains the same and the route remains the same. The other vaccine that is given at 6 weeks or first contact after 6 weeks of age is the pentavalent. The pentavalent, like the name suggests, is 5 in 1. We have the diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenza type B. It is called pentavalent 1. The dosing is 0.5 ml and the route is intramuscularly given on the outer aspect of the left thigh. So it is given via IM route where on the left thigh, upper outer aspect. These landmarks are very important for you to know. Pentavalent 1, 0.5 ml on the left thigh, upper outer aspect or the lateral upper aspect of the left thigh. The other vaccine that you must give them at 6 weeks or first contact after 6 weeks is the pneumococcal vaccine. And then we call it PCV 10-1. That is the pneumococcal vaccine 1. Again, the dose is 0.5 ml. Given IM also, it is also on the upper outer aspects of the thigh, but this time it is on the right thigh. So this child is going to be receiving 2 injections at 6 weeks, or if they're coming to you for the first time after 6 weeks of age. You will give them 2 injections. The DPT1 on the left thigh, upper outer aspect, and you also give them the pneumococcal vaccine on the right thigh at the upper outer aspect. The other 2 are orally administered, the OPV1 and the rotavirus 1. For the rotavirus is 0.5 ml or 5 drops, and it is also given orally. So 2 oral vaccines, rotavirus 1 and OPV1, 2 drops of OPV1, 5 drops of rotavirus, both given orally, and 2 injections, one on the right thigh, the other on the left thigh. The pentavalent one will go to the left thigh and the pneumococcal vaccine will go to the right thigh. Very important for you to remember. Then at 10 weeks of age, so when we say 10 weeks, we are referring to those babies who were born in hospital, they received the birth doses, they came back at 6 weeks, and now they're coming back at the age of 10 weeks. Then we have the other group of babies who perhaps were not born in hospital, but they were captured before 2 weeks of age or any other time for BCG. They have received their BCG, then they have received perhaps their birth polio. They have come in maybe at 6 weeks, anytime at 6 weeks or anytime after 6 weeks. They have received their pentavalent 1. They have received the pneumococcal vaccine 1. They have received the oral polio vaccine 1 and the rotavirus 1. So the difference in the first and 2, the 1 and 2 are 4 weeks or is 4 weeks. So for the child who came in or the infant who came in at 6 weeks, they'll be coming back at 10 weeks. For the infant who came in either at 6 weeks for the first time or they came in any time after 6 weeks, they will receive the 1 doses and then you will give them an interval of 4 weeks so that they can come for their second doses. So it will be 4 weeks after OPV1 and Penta 1 and pneumococcus 1 and rotavirus 1. So the dosages at this time are referred to as OPV2, pentavalent 2, pneumococcal vaccine 2, and rotavirus 2. The doses do not change. 2 drops for oral polio vaccine administered orally, 0.5 ml of the pentavalent. The site of injection does not change, is on the upper outer aspect of the left thigh intramuscularly. Pneumococcus, again, the dose does not change and it's also given IM on the right thigh upper outer aspect. So notice that the doses do not change, but the naming changes from 1 to 2. Again, you will give them a 4-week interval for the next date or appointment. So if they are 10 weeks, these are following the usual schedule, they have no delays, then they will be coming in at the age of 14 weeks. If there are those who are now just being given the 4 weeks interval, now they are coming in 4 weeks, you're giving them a new date 4 weeks after the date of the second doses. So we are going to give the 4 that we gave initially. So we'll have the oral polio vaccine 3, pentavalent 3, pneumococcus 3, rotavirus 3, and then we have an additional one, inactivated polio vaccine. The inactivated polio vaccine is not given orally. It is given intramuscularly. So let us see. The oral polio vaccine 3, the dose does not change. It is still 2 drops administered orally. The pentavalent 3, the dose does not change. It's still 0.5 ml given on the left thigh upper outer aspect intramuscularly. So those do not change. Pneumococcal vaccine, the dose again does not change, and it is again IM on the right thigh upper outer aspect of the right thigh. The rotavirus remains orally administered 5 drops. It doesn't change. Now, there's the new entrant, the inactivated polio vaccine. The dose is 0.5 ml given intramuscularly, but then this one is given into the upper outer aspect of the right thigh. So they'll be sharing the thigh with the pneumococcal vaccine, but you don't give it at the same site. You have to move at least 2.5 centimeters away from where you gave the pneumococcal vaccine, and that is where you give the inactivated polio vaccine. I hope that is clear. So we have the usual 4 vaccines, but now they are the 3rd doses. Then we have a new one, the injectable polio vaccine. And then you're giving it on the same right thigh like the pneumococcal vaccine, but you have to give an interval of 2.5 centimeters from the site where you gave the pneumococcal vaccine. Then the child goes home and is given a return date for when they are 6 months old. Now we have the vitamin A here. Vitamin A is not a vaccine, but it has been incorporated in the National Immunization Schedule to take care of the vitamin A deficiency, which is common in babies or infants who are being weaned. So at the age of 6 months, we will incorporate vitamin A, and the dose is 100,000 international units administered orally. Now, the vaccine that is administered at 6 months are two. One is not for all children, but one is for all children. So measles and rubella combination, and sometimes you can get measles, mumps, and rubella, the MMR, but in our national schedule, we are having the measles and rubella combination. So the dose is 0.5 ml. This one is administered subcutaneously on the deltoid muscle of the right upper arm. Subcutaneous on the deltoid muscle of the right upper arm. Now, the 6-month dosing of measles and rubella, again, is not for all children. This one is practiced when there is a measles or rubella outbreak or in children who are HIV infected and are not severely immune suppressed. That means, you remember we said live attenuated vaccines are not indicated in HIV infected children who are symptomatic, which means their immune system is already compromised. We only give to HIV infected children without symptoms of HIV disease. Therefore, we are saying once again that the measles rubella combination that is administered at 6 months is not for all children. It is for children who are HIV infected without signs of disease, or in cases where we have a measles rubella outbreak. The dose is 0.5 ml administered subcutaneously on the deltoid muscle of the right upper arm. Then we also have the malaria vaccine. Again, the malaria vaccine is not administered to all children. It is only administered to children who are in the high-risk counties. And here I'm going to give you an assignment. I want you to go and find out which are the counties that are listed in Kenya as being high risk for malaria. If you'll be working in any of those counties, then you must remember to give those children the malaria vaccine at 6 months. The dose is 0.5 ml given IM on the deltoid muscle, but on the left side, on the left upper arm. Do not confuse. The measles rubella is subcutaneous, deltoid muscle of the right upper arm. The malaria vaccine, the same dose like measles vaccine, on the left hand, upper arm rather, intramuscularly. And it is not for all children, only those children who are residing in the high-risk malaria zone counties, which I want you to go and find out as your assignment. That means if there is no measles outbreak, the child is not HIV infected without symptoms, it is not a high-risk malaria zone, then the only thing you do at 6 months is to give the vitamin A supplementation. That is very important for you to remember. Then these children go home and you give them a return date when they are 7 months old. And again, this will only happen for those who are living in the high malaria risk counties. These are the ones who come back for the second dose of the malaria vaccine. The dose does not change, the route and the site do not change. Then the child goes home, or the infant, and you give them a return date for 9 months. When they are 9 months old, sometimes mothers may just forget to come back, and then you may be meeting them again after 9 months. Whichever is the case, if they come on time, well and good. If they delay, you still give them now the official first dose of the measles rubella vaccine. The dose is the same, 0.5 ml. It's administered subcutaneously, doesn't change, on the deltoid muscle of the right upper arm. Now, again, there is another vaccine, the yellow fever one. Again, it is not given to all children, only those residing in counties that have been listed as being high risk for yellow fever. And again, I want you to go and find out which are the counties that are listed as being high risk for yellow fever. If you'll be working there, then those children, besides receiving the measles rubella vaccine, they must also receive the yellow fever vaccine. The dose is 0.5 ml, administered subcutaneously on the deltoid muscle on the left upper arm. So it will be on the opposite of the measles. So this is subcutaneous. And then we have, if again you'll be working in the high risk counties for malaria, these are children who will be receiving their third malaria vaccine. Remember, I told you it is still on the deltoid muscle on the left arm. So you see, you'll be giving, if the county doubles up for high risk for yellow fever and also malaria, then this child will be receiving 2 injections on the left side. One subcutaneous and the other is IM on the deltoid muscle. The IM one will be the malaria vaccine and the yellow fever will be subcutaneous on the left, and then they will have received the subcutaneous one, measles rubella, on the right deltoid muscle. And then the children go home. And if they are girls, or before we reach there, they go home, and at 1 year, they come back, not for any vaccine, but for the second dose of the vitamin A supplementation. And now you see they're older. They're not infants anymore. They're now 1 year old. At that age, the dose is no longer 100,000 international units, but 200,000 international units administered orally. This, again, I'm saying is not a vaccine. However, it is a supplement, a nutritional supplement, given 6 months apart. So you'll be giving it at 6 months, 1 year, and 18 months. When they are still infants at 6 months, the dose will be 100,000 international units. When they are 1 year and also 18 months, the vitamin A dose is 200 international units administered orally. Again, at 18 months, they will receive the second dose for the measles rubella vaccine. So the second vaccine, and we shall see how you decide which vaccine is valid or not valid. So they received their first dose at 9 months, so 9 months apart. So you're meeting them either at 18 months or any time after 18 months. They should be able to receive their second dose of measles rubella. The dose does not change, the route does not change, and the site does not change. Okay? So we've talked about age 12 months, vitamin A supplementation, age 18 months, vitamin A supplementation, as well as the second dose for measles rubella. Note or notice the increase in the dosage of vitamin A supplementation at age 12 months and 18 months. Then they go home and they come back at 2 years of age 24 months. And at this time, if you are in a high-risk malaria zone, they'll be coming back for the 4th dose of malaria vaccine. The dose does not change, the route does not change, and the site does not change. 0.5 ml intramuscularly on the left deltoid muzzle. So the 24-month malaria vaccine is only for those children who are residing in the high-risk malaria zone counties. Now the children can go and continue living their lives. They're healthy, they're protected, and then at 10 years, so from 10 years up to 14 years, we now want to give them the human papillomavirus vaccine 1. So they receive in total 2 vaccines, 6 months apart. So if you catch them at 10 years, they'll be coming back at 10 years and 6 months. That is 6 months apart. If you catch them at any other time after 10 years, within 14 years, you give them the first dose, then you give them a return date 6 months after that. You give them then the human papillomavirus vaccine 2. The dose is 0.5 ml. It doesn't change irrespective of the dosing. And then it is given intramuscularly on the left deltoid muzzle. The site, the dose, the route of administration do not change. Please note that the schedule we have talked about represents the minimum ages and intervals at which each vaccine is supposed to be administered, which means if it is 6 weeks, that is the minimum age. That dose is not valid if it is given before 6 weeks. If the interval is 6 months, you can only give it after 6 months but not before for it to be valid. So we are saying that the ages are the minimum acceptable and the intervals are also the minimum acceptable for the vaccine dosage to be valid. So if a vaccine dose was mistakenly or mistakenly given at a too young age for what is listed or recommended, or at less than the minimum interval as per the schedule, that means instead of waiting 4 weeks, perhaps it was given at 3 weeks, then that vaccine dosage is not considered valid. It is discarded and it must be repeated at the right time. That means if a child got a repeat dosage at 3 weeks interval instead of 4, you have to ignore that and give that dosing again at the age after when the 4-week interval date reaches. That's very important for you to remember. So an example is this. If a first dose of pentavalent vaccine is given before 6 weeks, which is the recommended, remember we said that pentavalent 1 is given at 6 weeks or first contact after 6 weeks, then it becomes invalid. And the schedule must be restarted. Also, if the second dose is given less than 4 weeks apart, then that dosage is not considered as valid. And therefore, the second dosing must be given at the correct timing. That is at the end of the 4 weeks after the previous dosing. That is the first dosing. So I hope that is clear. What about those children who are HIV exposed? They are HIV infected. What do we do about them? Number one is to remember that HIV infection is not a contraindication to vaccination, including the live attenuated vaccines. It is only those children who are symptomatic that should not receive the live attenuated vaccine. So we are saying that all children even if they are HIV positive, but they are asymptomatic, they should receive their due vaccines according to their age, whether those vaccines are listed as live attenuated or not, because they are not symptomatic. It means their immune system is not compromised. So we are saying this child should still receive their usual doses of vaccines. However, we are saying that when it comes to the measles vaccine, you remember on the schedule we said that if a child is HIV positive, then they receive the early measles vaccine at 6 months, but they will still receive the usual dosing of measles vaccine at 9 months and also at 18 months, according to the schedule. In a situation where, as a healthcare provider, you are not able to establish the HIV status of a child, then the World Health Organization recommends that live attenuated vaccines should not be administered to children who are symptomatic for HIV infection. That means when you do the module on pediatric HIV, there is what we call the presumptive diagnosis of HIV in a child, where you are not able to conclusively, by way of the laboratory, to make a diagnosis of HIV. However, this is a child with non-HIV exposure, and then they're also presenting with HIV-defining symptoms. Those children are presumptively considered to be HIV infected. They are symptomatic. They should not receive the live attenuated vaccines. Very important for you to remember. Having said that, then let's look at some of the adverse effects associated with various vaccines. We start with the BCG vaccine. This one, complications, like I said, are commonly associated with the wrong administration. If the administration is not done correctly intradermally, and therefore it is done subcutaneously, then the likelihood of complications is obviously anticipated. Some of them include lymphadenopathy. So a child may have lymphadenopathy, that is swelling of the lymph nodes, and it is usually the axillary and the supraclavicular lymph nodes. And sometimes this lymphadenopathy may develop what we call a cold abscess, and this abscess may break and discharge pus. Sometimes also there may be a child may develop a chronic ulcer at the site of the injection. If any of these things happen, then there is what you should do. Number one, if there is pus, it should be drained. If they have developed an ulcer, the ulcer should just be cleaned and kept clean. Okay? And in the unlikely event that maybe they had immune compromisation that was overlooked or was not noticed, and they have developed the disease, because remember BCG is a live attenuated vaccine, and they develop the disease, then they should go through the entire treatment. DPT. DPT is associated rarely with what we call pertussis encephalopathy. In this case, the children will usually develop seizures. This is a rare complication, and it is mainly or commonly seen when it is given in older children. Commonly, DPT is associated with high fever within 24 hours after it is administered. And also, there will usually be pain at the site of injection. What do you do? In this case, if the fever is too high and also the pain is much, then antipyretics, which usually double up as analgesics, also can be used. Brufen is preferred, and then please, this particular vaccine should not be given if the child comes in and they already have a high fever. Because remember, one of the adverse effects associated with DPT or pentavalent is high fever. So you do not want to give it to a child who already has high fever coming in for vaccination. Rather, control the fever, look at what is causing the fever and treat it, and then give the pentavalent or DPT. Measles vaccine. It is associated with the development of a fever, which is usually mild, and this happens around 1 week up to 10 days after the measles vaccine has been given. Other patients may also develop a mild rash a few days after the measles vaccine has been given. A few may develop seizures, measles encephalitis. What do? You just need to reassure the mother. These manifestations are usually self-limiting. They are not serious. However, understand that the state of severe malnutrition is a state of immune compromisation, and therefore, if a child has severe acute malnutrition, they should not receive the measles vaccine because of the risk of developing measles infection. So what you do is you reverse the state of malnutrition, and maybe within a week after now you're doing your catch-up growth, they are already out of the risk period, then you can be able to give them the measles vaccine before they go home. Polio vaccine has not been associated with any adverse effects so far. At this juncture, let us look at the cold chain, how to manage vaccines, and the cold chain maintenance. This, like I said, is going to be a review because the details of vaccine care and management, storage and all that, and transportation, and the maintenance of the cold chain are extensively covered in community health. So let us look at the cold chain. How do we describe the cold chain? This is a system of storing and transportation. So there is storage and transportation of vaccines at recommended temperatures from the point of manufacture to the point of use. That means if a vaccine is being manufactured, for instance, in France or any other Western country, it has to be transported to Kenya. It has to be stored at optimal temperatures, and that potency must be maintained at the point to the deepest, farthest region or village where a child is and needs this particular vaccine, which we are calling the point of use. So the equipment that are used in the cold chain management are freezers, then we have refrigerators, we have cold boxes, these are used during transportation, vaccine carriers, again during transportation and administration, and then we have ice packs. So look at that. This is where the company is that is manufacturing the vaccine. At this point, once the vaccine has been manufactured, it must be stored at the optimal temperatures, as we shall see, okay, and protected from light, depending on how sensitive it is to light. Then from the company, it has to be transported via air. Again, when all vaccines are being transported, they must be maintained at a temperature of 2 to 8 degrees. And some which can withstand freezing then can be transported at -15 to -25 degrees Celsius. So the vaccine has been manufactured. It has now been airlifted or transported via air. It has now come to Kenya, for instance. And now we have the national stores, the central stores. Here again, the temperature must be maintained at between 2 and 8 degrees Celsius. And for those that are not freeze sensitive, it can be frozen at 15 to 25 degrees Celsius. From the central stores, the vaccines need to be transported to the regional stores. Now, in the vehicle or in the van, again, temperature must be maintained accordingly. At the regional stores, the temperatures again must be maintained accordingly. From the regional stores, the vaccine needs to be transported all the way to the county stores, okay, to the county stores. So during this transportation, again, the temperatures must be maintained accordingly. At the county or district stores, again, it must be transported to the healthcare center, okay? So again, the temperatures must be maintained during transportation, at least 2 to 8 degrees Celsius, and then they come to the health center or the level 4 or whatever level hospital it is, and they are stored again with the temperatures in mind. Therefore, you can see all along we are making sure that the temperature, these vaccines are not being exposed to warmth and they're not being exposed to light for those which are light sensitive. Now, from this place, either now they're going to the dispensaries or they're going for health outreaches, all this way to where the mother and the child are. During this time, the temperatures must be maintained, and they are being now, the vaccines are being carried in the cold boxes, you know, and the other vaccine carriers up to the mother. And here we have the ice packs where the vaccines should be resting between the clients as they come in. So this is what the cold chain looks like from the point of manufacture all the way to the point of administration to mother and child. These temperatures must never be broken. This chain must never be broken because it speaks to the potency of the vaccine. So we shall briefly look at the sensitiveness of the vaccines to heat, and this is in a descending order. From the one, BCG is the most sensitive to heat as compared to DPT, but all these are sensitive to heat. So it is most sensitive to heat after reconstitution, but it is still sensitive to heat, but less so before reconstitution. That means once BCG should not be exposed to light unnecessarily because it will lose its potency. Then we have the other sensitivity, which is to freezing temperatures. All vaccines should be kept cold, but not all can withstand freezing. Some are denatured or destroyed because of freezing. And they are like we can see here. We have the hepatitis B, DPT, diphtheria and tetanus toxin. They are sensitive to freezing temperatures. And again, they are arranged in order of the one which is most affected by freezing to the least. But all these are affected by freezing. So this table here brings in the detail. Heat and light sensitive vaccines. You can see here. Heat and light sensitive vaccines. BCG, OPV, measles. I don't know if you noticed that all these are live attenuated vaccines. So BCG is relatively heat stable but very much light sensitive. OPV is sensitive to heat, and measles is also sensitive to heat and light. All these three vaccines are not damaged by freezing. That means they can be frozen. And when they are being transported to the primary healthcare provision site, they should be maintained at between 2 and 8 degrees Celsius. That is in the van or on the bicycle or on the motorbike or in the tuk-tuk. Whatever is being used, the container must always be maintained at 2 to 8 degrees Celsius, and then they are put into the storage and they are stored accordingly. Then we have those that are sensitive to freezing. DPT, hepatitis B, diphtheria and tetanus, and then the tetanus toxoid. DPT is relatively heat stable, and so is hepatitis B, and so is diphtheria and tetanus and the tetanus toxoid. However, these should not be frozen. It means even if the temperatures go below 0, for DPT it should never go below -3 degrees Celsius. For hepatitis B, it should never go below 0.5 degrees Celsius, and diphtheria tetanus, it will usually freeze at -3, and so is the tetanus toxoid. So, and these vaccines, we are saying they're sensitive to freezing, they should not be frozen. When they're being transported, they should be maintained at 2 to 8 degrees Celsius. ILR, as you can see, refers to ice-lined refrigerator. So we are saying at the primary healthcare level, all vaccines are kept in the ice-lined refrigerator for a period of 1 month at the temperatures of 2 to 8 degrees Celsius. They will remain potent to that extent. This information may look much, but it is very important because you will find yourselves at the health center, you will find yourselves at the level 4 and 2 and 3 hospitals, and you may be the in charge, and so you must know how to store these vaccines in order to make sure that the cold chain is not broken, and also even when you're maintaining the cold chain, you're also not denaturing the vaccines or destroying them in the process, and so potency must be maintained. How about the diluents that are used to reconstitute the powdered vaccines? We are saying that all diluents at all storage of vaccine transportation, a cold chain monitor must always accompany all vaccines, whether in cold boxes, vaccine carriers, or portable fridges. Then we are saying the temperatures, that means that all these devices should have a thermometer, and which is recorded, checked and recorded all the time on the chart, so that we can know. Anybody else coming in later can know how the cold chain has been maintained, what were the temperatures at what times. Therefore, we are saying that the temperature reading must always be between 2 and 8 degrees Celsius. Then the diluents also need not to be transported at these temperatures. Diluents are fairly stable. However, when they are being stored before they are used to reconstitute the vaccine, then they should be of the same temperature. They should be cooled. Okay? So we are saying that at the facility level, all diluents must be stored in the vaccine refrigerator and in the same tray as their respective vaccines. This is very important. Remember, during storage, we say that they don't have to be transported at strictly 2 to 8 degrees Celsius. However, at the facility level, before use, they need to be stored together with their respective vaccines on the same tray in the refrigerator. Why is this important? Because if the diluent is warm, it is going to denature or reduce the potency of the vaccine when it is being used to reconstitute it. So this is to ensure that diluents are at the same temperature as their respective vaccines at the time of reconstitution, so that the vaccine potency is maintained. There's no need, no point of administering a vaccine that is not potent. Also remember that diluents are usually supplied together with the respective vaccines. And so it is very important as a healthcare provider that you use the specified diluents for the specific vaccine that you are reconstituting, and you must follow the instructions as given by the manufacturer. These instructions are very important to follow, because if they are not followed, then you stand a risk of losing the potency of the vaccine. We're also saying that if the dilution of the vaccine is not done correctly, again, this tends to increase the risk of developing adverse reactions after the vaccine administration. Another rule is that in the vaccine refrigerators, nothing else is supposed to be stored there. Only vaccines and their diluents in their rightful chambers should be stored in the refrigerator for vaccines. Please, 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 laboratory reagents should never be stored in the vaccine refrigerators. All vaccine refrigerators and freezers should have an emergency plan that is pasted on the door so that in case of a breakdown, in case of a problem, in case of a malfunction, then the healthcare provider that is on duty should be able to know who to call. That means what to do must be written clearly and labeled, and also who to call, the telephone numbers and all that must also be clearly specified and labeled on the refrigerator. Okay. That brings us to the end of this second session on immunizations. Reference materials have been the Kenya National Immunizations Policy Guidelines of 2023 and also the Immunization Handbook for Medical Officers. This is published by the Government of India. With that, we have come to the end of this session in our series on introducing immunizations. I want to say thank you for your time. Thank you for listening to me. Let everybody know that this lesson has been going on. Share the video. Prepare your lesson questions. Prepare your thoughts. We shall be discussing and going through them when we meet in class. Thank you very much. Have a blessed day.